And the fourth breakout was on clinical management and public health interventions, and Dr. Lynn Goldman will describe that group's deliberations.
I should start by thanking George Sod and Stephen Whitehead for giving us some extremely thoughtful presentations that helped to kick this off. So, in thinking about both clinical management and, did I go the wrong way?
Those are my slides before.
It's, okay, somebody's, oh, okay, thank you. I think that's not my first slide. There we go. So there are several issues that we thought were important, and I'm going to go through them one at a time, but, and there's a little overlap here because I think that when it comes to public health intervention, but also clinical management, especially epidemiology starts to come into play, but also some of the other things that you've already heard a little bit about. But we thought establishment of causality, particularly for maternal-fetal transmission and causing microcephaly, was extremely important, and that there are several issues that needed to be addressed. One being the biological plausibility for the relationship, the role of the placenta, and is the virus indeed easily moving across the placenta to cause an in utero infection, as it appears that it might from some of the case reports, but also the neuropathological evidence that the virus is actually causing CNS damage. But we also felt that there need to be epidemiology studies to look at health outcomes in babies, whether cohort studies in high infection areas or case control studies that might look at either microcephaly or Guillain-Barré. That the studies to date don't adequately measure effect levels. They really weren't designed to do that, and they don't control for potential confounders. As was said before, that we would need better molecular tools for examining Zika virus exposure retrospectively, especially for case control studies, and better definitions of the cases and the outcomes to look at a full spectrum of what the birth outcomes might be. Management of pregnancy was a concern in terms of the guidelines that we heard about earlier today and the evidentiary basis for those guidelines. One question that we thought needs to be addressed is whether there's maternal-fetal transmission in asymptomatic women who are pregnant. And given that some of the women who had children with microcephaly had not recalled that they had an infection, that might be a recall problem, and it might be that there's asymptomatic transmission. Research on risk communication and issue in the United States certainly is a lot of concern from those who might become pregnant or who have traveled or have a sexual partner who has traveled to an area of transmission. And how do we communicate the risks? What's the information that should be communicated? How do we communicate that accurately? In terms of some of the elements of the pregnancy algorithm that has been recommended to practitioners, certainly the serum Zika value results, that's a test, a clinical test that's recommended to be used, but what's its actual sensitivity, specificity, and predictive value, especially in a population that's not very exposed, and as well the ultrasounds and are the ultrasounds going to provide the information that people wish to have at an early enough stage to be informative? It's consideration about establishing a registry, given that there is this protocol, this algorithm that's been developed, and that people are testing women. And should those women be in some kind of a registry and followed up over time, perhaps follow up the outcomes of their pregnancy, given that it seems that most of them are having the serology done at the CDC. And last but not least, the knowledge, attitudes, and beliefs about the use of DEET and other insect repellents in pregnancy. Will people do that? Is that an alternative? I should say we also had conversations about contraception that were not around research, but more around some of the complexity about contraception globally and even in the United States, the fact that everybody does not have medical coverage for contraception. In the area of clinical assessment, this overlaps with the last slide, that, again, this issue about the Zika PCR tests and the sensitivity, specificity, and predictive value, how you interpret those results. The presence of Zika virus in various bodily fluids, that has implications both for public health and clinical management. In clinical management, one has to be worried about infective fluids. And so it's already been raised, is it in the semen? But the questions people ask, how long do they need to abstain from sexual intercourse? It's a question that clinicians need to be able to answer. The risk from blood transfusions, the possibility of Zika virus persisting in breast milk, and should there be advice given to lactating women about that. And also the fact that because there's a PCR test in use, that the Zika that is detected may not be living, viable Zika virus, maybe Zika RNA, and are possibly creating alarm or causing concern among people who do not need to be concerned. And I think general agreement that for every aspect of public health and clinical activities around this, that there need to be more rapid, accurate, and more specific Zika tests that could be actually applied in the field as well as in clinical settings. Management of travel is often something that comes up in public health when we're dealing with a communicable disease that's of global consequence. What is the evidence base for providing advice to returning travelers? What kind of advice should we be providing them? Should we be advising them to self-monitor? Does that make sense? If they are returning to an area that has Zika, has Aedes mosquitoes like South Florida or South Texas or Southern California, should they be using DEET to prevent transmission of potential Zika to the mosquitoes in that region, whether they're symptomatic or not? Are there stigmas that are being created where whole areas are being painted with the same brush as being areas of Zika transmission? Which is a risk communication challenge. Is it possible to better define subnational areas that are areas at risk for Zika transmission instead of whole broad regions being characterized as areas with transmission? And then the possibility in public health of some cohorts of people who travel frequently, expats who work abroad, the military, retirees, migrant workers, that might be able to be recruited into surveillance or epidemiology studies to understand more about transmission. Vaccines and pharmaceuticals are of obvious interest for either public health or for treatment clinically. There are no current vaccine candidates that seem to be just in the pipeline, although there is some research, more basic research that's being done to identify potential targets. And it seemed that even a rapid deployment of a vaccine, an effort would require several months to years. It was noted by a few people in the group that if one could develop a multivalent vaccine for several of these arboviruses, that might be a more sustainable approach in terms of providing a vaccine that would have broader applicability. In terms of therapeutics, there has been press about an IV immunoglobulin that's being developed that potentially could be used to treat exposed pregnant women or people with Guillain-Barré, speculatively. There are no known targets for pharmaceuticals to prevent transplacental transmission or effects, but it would be nice to identify those. And several barriers were identified in this area, including time, bioethical considerations, and bringing things to the market very, very quickly, and resources, availability of resources to develop these things. In general, there were a number of issues that our group discussed that we thought needed to be brought to light that might help to facilitate research in public health practice. Some of these have been mentioned already. The capacity to ship samples across borders, the availability and appropriateness of personal protection equipment. That's what PPE means on this slide, such as for health surveillance workers who are working in Zika transmission areas. Improving data sharing and availability, coordinating research networks, many issues around the area of pregnancy-related research in terms of the need to incentivize industry participation in that, the bioethical issues that arise, as well as some work that was mentioned that the National Vaccine Advisory Committee is working on with looking at vaccines in pregnancy. I think some of the other ideas, such as pre-positioning of standardized consent study protocols and other disaster science resources, might be more applicable to the next problem like this one, not necessarily this one, as well as an idea that perhaps under the Affordable Care Act, there could be some incentives for the research and or that the federal government could work harder to improve our health IT systems so that we can coordinate data. Even our data in the United States between mothers and their infants is very hard to put together. And then last but not least, ways that we can improve the long-term preparedness and engagement of the health system as well as communities in our country. So thank you.
Thank you very much.